and welcome to today's episode of A Cancer Conversation with the Georgia Cancer Center. My name is Chris Curry, and I am the Communications and Marketing Manager here at the Georgia Cancer Center. Today's conversation is going to be with Dr. John Henson. It's going to be about brain cancer. May is Brain Cancer Awareness Month, and so Dr. Henson is a neuro-medical oncologist here at the Cancer Center. Going to share some information with us about brain cancer, as well as some other programs that you have helped bring to the Cancer Center to help our patients and offer some new treatment planning and things of that nature.
Perfect.
All right. Thank you for joining me for today's conversation. Let's begin by learning a little bit more about you. How did you get involved in being a neuromedical oncologist? What led you down this career path?
Happened while I was at Vanderbilt as a neurology resident. So what happens when you're training is basically you are dating subject areas. It's a whole lot like a social thing. Yeah, you're learning some things and you master some techniques and whatnot. But in reality, what you're doing is that you're looking at all the subspecialties within something like neurology. And you're saying to yourself, which one of these is the place where I think I can make the most difference with my life? What's most intellectually interesting to me? What's going to work well for me for the next, hopefully, 35 or 40 years? Mm-hmm. So I'm in my neurology residency, and I'm going through all the rotations, and I liked neuro-oncology. It was a period of time where the genetics of brain tumors were the cracks were just opening up where we could actually study that. And another important component of it was that, unlike many areas in neurology, you can actually see on an MRI scan what's happening to a tumor, whereas, say, for example, something like Parkinson's disease or ALS, you can't follow it on an MRI scan. And I love neuroimaging. And so, the ability to actually see what was happening to my patient's tumor as we would change treatments and whatnot was very interesting. And the third thing was that I had an emotional resonance with brain tumor patients. It was something that's just part of who I am. I've always had a very tender spot in my heart for cancer patients, and so it was a perfect fit for me. And frankly, in 35 years, I've never looked back.
What is it like for you working with those patients? Let's talk a little bit more about that emotional resonance you had.
Well, one of the most interesting things about that is this business about emotional availability, you might call it. So in many circumstances in life, we meet people, we interact with them, and there are our own self-built layers of issues on our things on our personality. When people are faced with a very serious diagnosis like cancer, there's a lot of stripping away of the superficiality of life. And many times patients will say, this is a really bad thing, but I have I'm living more deeply because of this, and so there are silver linings. So one of these issues is that it allows for emotional interactions, a direct interaction with a patient in a way that most medicine doesn't really sort of give itself to that. And I find that very, I like making friends with my patients. They all become, personal friends. And that emotional availability is very, very rewarding for me. And so I think, that's an important part of it from the physician standpoint. That's an important part of me interacting with patients. And, a story I've occasionally told is that in my early life, I had to decide between becoming a doctor and a pastor. Some really famous pastors in my family, and I decided to become a doctor. But in this field, you actually get to do some of both. It's very interesting in that regard. So it fits me to a T. Okay. I was lucky. I found the right medical partner for myself.
That's awesome.
Yeah.
So let's talk a little bit about brain cancer here. Talk about the different forms of brain cancer. How many different types are there, and how are they different?
There's about 100 different types. So the fact actually comes out of the number of different kinds of cells there are in the brain. Everybody understands that there's electrical cells in the brain. Those cells have to communicate, so there's a wire coming from the electrical cell to go somewhere else. the cells that form each part of all of that, the internal structure of the brain, different from each other. And each one of those cells can have a cancer named after itself.
Really?
So if you have 100 different types of cells in the brain, let's say, and there are actually many more than that, but let's just say that there are 100 general types of, you get 100 different tumors. And so many of those are very, very rare. And you know, someone who does this intensively for their entire career might see a handful of these the rare cases, right? And then there are the very common ones like glioblastoma, for example, and meningioma, which isn't a brain tumor per se, it's a tumor of the covering of the brain. But there are lots and lots of different kinds, and they each have their own sets of behaviors, but none is even the same. If you look within a category, there's still a big bell curve, like all of biology. There's a big bell curve of behaviors, even for the most malignant tumors. We now find that about 20% of our patients with glioblastoma, which is is the bad tumor in our field, about 20% of those patients are living 2 to 3 years now.
That's great.
Whereas when I came into this field, that was almost never the case. It was like 1%. And so there's been big advances, but the point I wanted to make is that there's variation in the behavior of the different kinds of tumors. I find that to be a very interesting challenge, kind of try to understand how this tumor might behave in this particular patient. And usually the answer to that is that we have a rough idea, but not a very accurate idea about the way it's going to behave. That's important because when people want to know what their prognosis is, we're not anywhere near as good at that as a lot of people would think that we are. And so you have to be very cautious about saying, this tumor is going to do X. What you have to say is, this tumor has a propensity to behave well or bad, or whatever the propensity of that class of tumor is. But we'll only know how your tumor is going to behave as we get a little further down the road.
Mm-hmm. 3 months, 6 months, a year?
Yeah, typically a year for the more malignant varieties of tumor. We'll have a good idea. With glioblastoma, for example, we'll have a good idea in a year how that tumor might behave. But even then, this business of prognosticating things like how long will it remain silent, if it starts to grow, can we put it back into a silent state, how long might I have to live, we have to be very cautious about pontificating on those things, because we just set up to be wrong.
Yeah.
And the older I get, the more humble I get about understanding what's going to happen with a particular patient. So what we do is that we assume the best. We swing for the fences with everybody, and we oftentimes that proves itself to be wise. Sometimes it's a very bad tumor, and we don't win.
If someone is diagnosed with brain cancer, what can they expect when they come to see you and your team here at the Georgia Cancer Center?
Well, the first thing that I would want people to know about that is that we have a team of people who work together on this single area in oncology. So if you are outside a large cancer center, for example, in many cases you would be treated by a doctor who sees many different kinds of cancers. In a cancer center like this, we have individuals who are dedicated to this disease, like myself. And then the team would be myself, a radiation oncologist for radiation treatments if needed with specialty in brain tumor. That would be Dr. Barrett here. We have Dr. Rutkowski and Dr. Vender, who are the neurosurgeons that deal with operating on brain tumors. We have nurse practitioners, nurses, pharmacists with specialty interest in this area. So the big advantage that we can offer patients is that this is what we do. So I think that's a very important point for patients to understand. And the second thing is that process of collaborating amongst the clinicians is very healthy here.
What sort of treatment options are available for people with brain cancer?
The range is from a tumor that needs to be observed, and that's something that's not intuitively obvious a lot of times. Sometimes the best thing to do is to watch carefully and do nothing until the appropriate moment. Once treatment becomes necessary, typically the first step in treatment is a surgical procedure. It accomplishes two things. Gives us a name of the tumor and removes hopefully a lot of the tumor. Now, for some tumors, it's quite straightforward to get all of it out at surgery with a brain surgery. But for the majority of tumors, they infiltrate into the brain, and it doesn't matter how much brain we can remove in a safe area in the brain, for example. It doesn't matter how much you remove around the tumor, there's still tumor cells that have escaped out beyond that. And then that's why these tumors have a high risk of regrowing. So we operate, and then typically that would be followed by a course, in many cases, of radiation treatment with a mild oral chemotherapy treatment. Then we have some relatively more recently developed treatments, one of which is an electrical treatment, which puts the tumor cells in an electrical field. And tumor cells have a hard time dividing. The charged molecules inside the cell don't divide well in an electric field, and that actually slows down tumor growth. It's very clear from the data that that's beneficial. Although it sounds a little funny, it's beneficial. And then we also have clinical trials, which are new treatments that seem promising, but we have to understand whether it really is the case or not.
I want to go back to something you said about the life expectancy of brain cancer patients. Can you talk briefly about the advances that you have seen in treatments and treatment options during your career?
Right. So that comment I made earlier about going from, let's say 18-month survival, year and a half, in a patient with a glioblastoma from about 1% to now roughly 15 to 20%. And that can persist out to 2 to 3 years. So the advances have come from better surgical techniques, better radiation with fewer side effects, and the addition of more effective chemotherapy treatments. You put those three advances together, and it has had, a reasonable improvement. The impact has been reasonable. I say reasonable because any improvement in the treatment of a malignant glioma like glioblastoma is big news. Nonetheless, we still have most of our work to do in front of us. We're not where we want to be in terms of controlling these tumors. We need bigger and better advances. Those are likely to come out of genetic and genomic insights into the tumor.
We're going to talk about genetics and genomics in just a minute. What are some of the most common questions brain cancer patients ask you, and how do you respond? What are your answers to their questions?
I think the one thing that everybody walks into clinic with is a fear of their own mortality. I would say that's is understandable, and so I think people are listening both for concrete verbal discussion about that, but they also listen to see how you respond to them as a physician, how I'm responding, and do I sense that there's hope for the person. They can read that in doctors, there's no question about it. And so I think even in situations where the tumor has clearly recurred and it's not responding to treatment, there's still a lot of things that we can do to make people's lives, even if not save them, we can make their lives better. And so I think there's a concern to try to learn how dangerous is this to me. People are very concerned about what it's going to do if they're working, in particular, if they're responsible for family members, children. What's this going to do to my day-to-day life? I think that's a big one. And how well am I going to tolerate the treatments? Is it going to make an invalid out of me to go through these treatments? And the answer to that is almost never. If something like that happens, then there was an unexpected event in the treatment.
Okay. Talking about hope and mortality, I imagine that you probably find yourself reaching out to the psychosocial program at the Georgia Cancer Center. Is that true?
We do. Mm-hmm.
How important is that program for your patients?
Everyone that's gone to see, for example, Dr. Bigham, finds her to be very, very helpful. And then our social work program, it's much more about the tactical things of life. You know, how am I going to fill out all these papers, and how am I going to manage the bills that come, must come flooding into the mailbox. The social worker in general is very focused on helping with those issues. Then we have psycho-oncology, where the real sort of grappling with emotional family dynamics, et cetera, that's where that happens. We find that to be very valuable.
And while treating patients with brain cancer is obviously a passion of your professional life, we can hear that and see that, you're also quite dedicated to the role genetics play. We talk a little bit about that in a patient's risk of developing cancer. Talk about the hereditary cancer clinic that you helped to start here at the Georgia Cancer Center.
Yep, another big passion of mine, and only moderately related to the brain tumor role that neuro-oncology role that I play here. A number of brain tumors arise in hereditary syndromes. This is where I got interested in this. And so we could see that there was an interaction between a hereditary factor, a gene, typically a single gene, we say monogenic, a single gene that would run through the family and put people at risk for brain tumors or tumors of the nervous system. So I got very interested in that a number of years ago and started a big clinic for neurofibromatosis, von Hippel-Lindau tuberous sclerosis out in Seattle, and that clinic was extremely successful and very helpful, I believe, to patients. And so I got further and further into sort of being interested in that area, and I went out to City of Hope in Duarte, California, and took a course in cancer genetic risk assessment.
Cancer genetic risk assessment.
So, for example, a woman has a 45-year-old sister who develops breast cancer. What's my risk? Are there genetic tests that I can take to help me understand the risk? And that ranges from breast, ovarian, pancreas, prostate, colon cancer, hereditary. I mean, there's a large number of cancers.
Not just breast cancer.
No, it's a very large number of cancers. That can be kidney cancer. It can be affected by a gene that runs down through the family and puts people at risk. So the interesting thing about this genetics work is that what the focus of this really is to try to find a gene that puts family members at risk, figure out who's got that gene that's abnormal, a mutated, or we say a variant gene, understand what their risk is and help them manage the risk. So another way to think about this is, and I think this analogy is very helpful. There are three big buckets of cancer care. The middle one is, I have cancer, I need help, treatment to save my life. That's what we spend 98% of our time and insurance dollars on, is in that middle bucket. Then you have survivorship, and you've got hospice. And at the front end of that, the first bucket is early detection and prevention. The field is moving strongly towards trying to keep people out of this problem rather than waiting until they get into the situation.
Which is probably a good approach.
It's so logical, right? Prevention, early detection. So what we do in clinic is that we the oncologists refer patients who have a concern for a possible hereditary problem. We do DNA sequencing typically on their blood. We might find in that case a gene that everybody knows about, BRCA1, so we can talk about that. A BRCA1 gene which elevates breast cancer risk over a woman's lifetime to 60 to 70%, high risk of ovarian cancer. If there's a patient in the family, an individual in the family with pancreas cancer risk there, so then we can figure out who in the family has that gene, put them into surveillance programs and find, in many cases, patients might choose to have risk-reducing surgery and have the body parts taken out that are at risk, right? If they don't actually need them to get along in life, we can remove those and take the risk to, in essence, zero. So we're moving with the genetics. What we're doing is we're moving into that first bucket of early detection, and in some cases prevention. And it's very, very rewarding work. And I tell you, this clinic has gotten so busy with this work that it's just remarkable.
Yeah.
And we started off with a half-a-day clinic. We're now running 2.5 full-day clinic. So five clinics in a row to handle the patients that have this problem and potentially have the problem of a genetic influence in their tumor. And it's remarkable. We'll find in an average week 1 to 3 early stage cancers that can be surgically removed, and if it hadn't been detected because we knew to look for that, it could have hurt the patient really badly.
That's incredible.
That's rewarding work.
Yeah, that's awesome.
Yeah.
Even 1 would be rewarding, but 1 to 3, that's great.
Yeah, it is great.
Are there any other new programs that you would like to share with those watching or listening to today's podcast episode that you're working on here at the Cancer Center?
Well, we have to talk about this new VHL thing, and I know that you're aware of this because you've been working with us on it, which I appreciate. Von Hippel-Lindau is one of these hereditary syndromes in which the body believes through altered molecular mechanisms that it needs to create more blood vessels. So it creates tumors related to blood vessels in multiple organs, von Hippel-Lindau. And it's hereditary syndrome. There's a gene, it's autosomal dominant, it passes down in families. Each family member has a 50-50 chance of getting the abnormal gene from whichever parent has it. And these cysts and tumors can show up in 10 different organ systems, basically. So it's not terribly common, but it is a very, very significant problem in a family with VHL, von Hippel-Lindau. So the von Hippel-Lindau Alliance is a national and now international organization. One of the things they do, it's not a medical organization per se, it's independent. But what they do is that they find centers or healthcare organizations that have enough interest and subspecialty expertise in all of those 10 places that we can actually put together a program to take care of these families. So it's got genetics, it's got neuro-oncology, it's got big renal component, it's got lung component. And so we applied for VHL clinical care center status through a fairly rigorous process. We applied for that. And last week, we were awarded clinical care center status with the VHL Alliance. We're really excited about that. Now, one of the things that's so important about this VHL is that historically it was treated mainly with surgery, occasionally radiation if things, in certain circumstances. There's a brand new medicine that was just approved, the FDA, for people with von Hippel-Lindau for their tumors.
Wow.
We want to be able to get that drug, which is a very helpful drug, into the hands and bodies of people who need it. And there's no better way to do that than to put a group of specialists together who can deal with the syndrome, put the word out that we're here to help people get that treatment.
I think you told me it's a team that's made up of 10 different people, isn't it?
Yeah.
That's awesome.
Yeah, it is.
So a true team effort here at the Cancer Center.
It is indeed, yeah.
All right. Are there any clinical trials going on right now? You know, clinical trials, obviously, we talk about making advances against brain cancer. Are there any clinical trials that are showing promise or that we offer here at the Cancer Center that people should know about?
Yep. And this is, at the moment, this is in the neuro-oncology part of, my work here at the Cancer Center. So we have an immunotherapy clinical trial for people with glioblastoma, where we're trying to get the immune system to do its fair share, as people say, to really attack the tumor and help control it. So that's a clinical trial for individuals newly diagnosed with glioblastoma, and it involves medicines that stimulate the immune system to attack the tumor. So that's a clinical trial we have for recurrent glioblastoma. We have a very early stage, what we call phase 1-2 drug that attacks a completely novel part of the tumor pathway. So we have that for patients with recurrent tumors. And then we also have a novel imaging agent that we're studying in brain metastasis patients, trying to help us understand the best way to take pictures of these lesions in the brain.
Okay.
And that's a trial.
Well, Dr. Henson, I appreciate your time today joining me for this episode of A Cancer Conversation. I have learned a lot. I always enjoy talking to you and working with you, so thank you for taking the time to sit down with us.
You're welcome.
And share this knowledge. Thank you all for listening, watching. Make sure to hit that subscribe button, and you can find us on Apple's podcast, Spotify, or any other location where you get your podcast, and also follow us on YouTube.